So as when I was taking a lot of classes, and students will always ask the first question, why you want to do assessment? The simple answer is from me is very simple, that the assessment are very important to identify what is the actual pathology the patient has. When you understand the actual pathology, then the treatment is very simple, as well as you are able to prevent the reoccurrence of the condition. So assessment is very, very important. Although we have very simple treatment, but the assessment is very, very important. So the basic part of the orthopedic or musculoskeletal assessment depends on the SOAP notes, right? It's a subjective, objective, assessment, and the plan. So what is subjective? Subjective is whatever the subject says. Whatever the subject says, called as the subjective, right? So when the subject says, like history of the patient, the demographic data, or the patient's pain assessment, all comes under subjective, because we are going to get the information from the patient only. So whatever the subject says is called the subjective. Objective is what a physiotherapist you are going to find out is the objective, right? So how we are going to identify it, whether the patient has this problem, that problem, your observation skills, your palpation skills, or the examination skills comes here in the objective assessment. Plus assessment stays for the functional assessment, as well as the assessment for the other areas also, right? And the plan. So treatment plan is what we are going to do. So from this we are going to move into the. So not audible. Is it not audible? Hello. Is that okay now?
Clearly audible here, sir.
Yeah. Someone has texted me that it's not audible.
I think they can reset their audio connection.
So from this we are going to move into the MCQ sessions. As like the last class, I have some few photographs as well as some questions which basically profound on the part of the musculoskeletal assessment only. And the photographs which says the deformities only. So you are able to find out what is the deformity is that. Right. So from this we are going to start with the first question of what is this? What the photograph says. So when you observe the photographs, you are able to identify what it says. It is calcaneal valgus. Okay, basically it is rear foot valgus. What? When we observe the foot of a patient like this, we are able to identify the patient having a flat foot. That is a perfect diagnosis of the patient. Right? The patient has a flat foot. When you observe the patient keenly, you are able to observe the patient have a calcaneal valgus in the foot itself. Right. So our first question is bone pain is how the bone pain is. What type of the pain the patient will experience? Is it a deep boring, dull aching, diffuse aching, or radiating? How the bone pain will be? Deep boring, diffuse pain, dull aching, radiating. The dull aching. Okay, so the answer for the question is deep and boring, right? So when we look at the pain description related structures, which was explained well in the orthopedic textbook, the muscle pain usually a dull aching or cramping nature, ligament or joint capsule are dull and aching, sharp shooting or nerve pain or sharp, right, lightening like or nerve pain, sympathetic pain or burning pressure like, or vascular pain or throbbing and diffuse, fracture pain is short and severe, right? So first of all, we have to understand what type of the pain the patient is complaining. Depends on the complaints, we are able to identify it is a muscular pain or a bone pain, joint pain or fracture. We are able to differentiate it, right? So from this, we are going to move on to the second question. The pain tends to feel deeply, indistinct boundaries, radiate segmentally without crossing the midline is called as A, acute pain, B, referred pain, C, radiating pain, or trigger point pain. The patient with a have to read clearly. The field deeply, indistinct boundaries, and without crossing the midline. Right. So there is no crossing of the midline. Is it acute pain, referred pain, trigger point, or radiating pain? We got one answer from Tanya. It's B, radiating pain, and the Joker, it is B, referred pain. B, Townsend, radiating pain. Okay, so the answer for the question is referred pain, because referred pain, when you read it, it feels deeply and it has indistinct boundaries and also radiates segmented. Right, the question number 3, deformity which occurs due to muscular contraction. Is it a static deformity, dynamic deformity, functional deformity, or structural deformity? Deformity occurs because of muscle contraction. Without muscle contraction, the bone is normally looked, but when the muscle is contracted, the joint or the joint goes to different deformities. Is it because of it's called a static or functional or dynamic or structural? Very good guess. The functional. But some more answers I'm expecting. The structural. How come the structural is it occurs? The structural deformity is the deformity where it present always. When you see a flat foot, the patient will have flat foot either in standing or sitting or weight bearing or non-weight bearing. That is the structural deformity. If a patient with scoliosis, you can see the scoliosis everything. That is structural deformity, or also called a static deformity. Functional deformity occurs when you do some functions. Like dynamic deformity is the correct answer, because the dynamic deformity is the one when you do a muscle contraction, the deformity occurs. That is called as dynamic deformity. Torticollis, there's contraction of sternocleidomastoid and the patient goes for one side of tightness. That is dynamic deformity. Right. Okay, so the next picture. So what you are going to identify from this picture? What is the condition called as? Any guess? Please just look at her nose and the cheeks. Very good. Butterfly rashes. So where you will find butterfly rashes? Which condition you will find butterfly rashes? In the SLE, systemic lupus erythematosus, right? So when a patient comes to you, first observe the patient. When you observe it and you find that the patient has different in the face or different in the structure, then you are able to identify maybe it is because of this. So butterfly rashes are very common in systemic lupus erythematosus, which is a condition related to the rheumatoid arthritis. So patient with arthritis are able to identify this. Right, we are going into the question number 4. Capsular pattern for the glenohumeral joint is flexion, extension, lateral rotation, medial rotation, adduction and lateral rotation, extension, abduction and lateral rotation, abduction and medial rotation. So capsular pattern. So what is a capsular pattern? First, you identify what is capsular pattern. Capsular patterns are found in all the joint which has a capsule. And the joint will go for tightness based on the capsular pattern. If it is a non-capsular pattern, we are able to identify. If the joint is not tightened based on according to the capsular pattern, it is called as capsular tightness. If it is not occurs as per the capsular pattern, then it is called as non-capsular tightness, right? So you can find it's a capsular injury or a non-capsular injury. Like adhesive capsulitis, you can find out the patient with CDD. Okay, the correct answer is D, because when you see the glenohumeral joint, and the glenohumeral joint affects first movement affected in the adhesive capsulitis or arthritis of the shoulder is a lateral rotation. So once the lateral rotation first affected, then the patient abduction was not able to do, then the second movement is medial rotation. So all these rotations and abduction are the first affected, and later on the flexion extension will be affected and the joint go for new stiffness. Whereas if the patient doesn't exhibit a lateral rotation, abduction, or any tightness on the lateral rotation, abduction, then we are able to identify it is a non-capsular pattern. So there is no capsule involvement. Maybe other structures involved. Is the muscle or ligament or the other structures involved. Like it is not an adhesive capsulitis. You can identify it. So every joint has a capsular pattern, right? So when you read our Maggie textbook, you are able to identify every joint as a capsular pattern, and based on that, the tightness will occur. Right. So question number 5 is very, very easy. During muscle power assessment, fair minus means what? Some but not complete range of motion against gravity. Complete range of motion against gravity with minimal resistance. Complete range of motion against gravity with eliminated position. Initiates movement if gravity is eliminated. So what is that? So fair minus. So usually we will see MRs getting muscle, medical resource council, that is medical research council grading, where we always say as a 1 to 5, right? So it is 0 is no contraction and 1 is flicker of contraction. But sometimes we have the other area also, right? So for this, the answer is the first one is A, some but not complete range of motion against gravity. That is, you see here, it is very clear in the picture. Muscle power grading, 0 is no contraction, 1 or trace is evidence of slight contraction, 2 is as what we read is 2 is complete range of motion with gravity eliminated. If the patient was not having complete range of motion but initiates the movement, it is 2 minus, whereas initiates movements against gravity is 2 plus. Plus 3 is complete range of motion against gravity. But the patient was not able to complete the range of motion, the patient was able to lift it, not full range of motion. So that is 3 minus is called as fair minus. Whereas 3 plus fair plus is complete range of motion against minimal resistance. 4 is complete range of motion against with some resistance, and 5 is with maximum resistance. So although we always read 1, 0, 1, 2, 3, 4, 5 in the MRC grading, but this also we are supposed to understand and remember. Only 2 here, 2 minus, 2 plus, 3 minus, 3 plus. Rest of all the same. Okay, we move on to the 6th question. Musculoskeletal pain has all these features. All the features have musculoskeletal pains, except generally lessens at night, aggravates by mechanical stresses, throbbing pain in nature, reduced with actions. So, which is not a musculoskeletal symptom. Tanya has put C, very good, very good. It is C, throbbing in nature, because throbbing pain always occurs in the systemic involvement. So, we can see a differentiation between systemic and musculoskeletal pain. Systemic involvement disturbs sleeps. It's a deep and throbbing pain reduced by pressure. When the patient comes with a back pain and the patient has a pain in the abdomen, when you press the abdomen, the patient's pain was reduced. So it indicates it is not a musculoskeletal, it is a systemic involvement. Constant or wave of pain are not aggravated with mechanical stresses and associated with some of the conditions like jaundice, fatigue, weight loss, tumors, and all. Whereas musculoskeletal condition generally lessens at night, sharp or superficial ache, usually decreases with activity, usually continuous or intermittent, aggravated by mechanical stress. When you apply some stress, then it will aggravate, but systemic pain doesn't aggravate. The common difference is that it depends on the pain. Usually musculoskeletal pain is like muscle pain is dull aching, whereas here is throbbing pain. Right, very good, fantastic picture. What is the picture says? What to identify from the picture? What is the name of the deformity? Windswept deformity usually found in rheumatoid arthritis and cerebral palsy. So windswept deformity. What is windswept deformity? One side of the knee goes for valgus, other side of the knee goes for varus. Whereas in osteoarthritis of knee joint, we are able to see only the bow legs. Whereas in rheumatoid arthritis, we can see this type of deformity. Patient with one leg goes for valgus, other leg goes for varus. This condition is also seen in cerebral palsy. These are common conditions where the patient exhibits the valgus as well as vas deformity. Windswept deformity. Okay, this is a common question asked by every examiner in the examinations. Acute pain means how many days is acute? Is it 1 day, 2 day, 5 day, 10 day? Which is acute? So the options are 7 to 10 days, 10 to 12 days, 1 to 2 days, or 8 to 15 days. Which is called as acute? Which is called as acute? 7 to 10 days is acute as per the textbook of life, right? So some examiners has asked me, like previously one day when the examiners came and fight me, give the evidence if he says that the 7 to 10 days is acute. Then I have shown the book textbook of orthopedics like Maggie, and he accepted this. So many senior therapists are not able to understand why this is called a acute, why this was subacute. Always you have to speak to the examiners with references. Otherwise, examiners will. Right, acute pain is 7 to 10 days, subacute pain is 7 days to 7 weeks, and chronic pain are more than 7 weeks. This is as per the David Knight, right? So acute pain is if the patient have pain for 10 days is called as acute, or for subacute is still the 7 days, that's 12 week is subacute, or 13 week is subacute, and the chronic pain is more than 13 weeks is more than 1.5 months is called as chronic. Okay, question number 8. Testing myotomy. Each contraction has to be held for at least dash seconds. 5 seconds, 10 seconds, 15 seconds, or 30 seconds. When you test the myotome testing, how many seconds that you ask the patient to hold it? Because when you ask the patient to hold it, you are able to identify there's a weakness is there or not. At least you have the minimum, you have to hold it. So is it 5 seconds, 10 seconds, 15 or 30? The correct answer is 5 seconds. At least 5 seconds you ask the patient to hold it. Most of you has put the correct answers, right? 5 seconds you have to hold it and identify whether the patient exhibits any symptoms or not. Right, question number 9. Very easy question. Signs of lower motor neuron lesion includes all except muscle wasting, loss of vasomotor tone, joint instability, or hyperreflexia. Very easy question. Everyone has said hyperreflexia. Usually it is hyporeflexia is the common in the lower motor neuron lesions, right? Hyperreflexia will not be there. But other features are the common features of LMN lesion, right? Muscle wasting, joint instability, loss of vasomotor control. Joint instability occurs because of wasting as well as because of the tone, hypotones. Right, question number 10. Pain related to specific activity is called as. When you do activity, the patient exhibits pain. What is that called as? It's a periodic pain, constant pain, episodic pain, or occasional pain. It's a periodic, constant, episodic, or occasional. What is the pain when you do certain activity called as? So it is called as the episodic pain because when you do some activity, the patient exhibits pain. Constant pain is a pain occurs when you do activity, not doing activity, the patient exhibits pain. Occasional or periodic pain are same. It occurs in some activity. When I stand erect only, I feel activity, but there is no pain on the sitting or lying. So episodic pain occurs only some activity. When a patient comes to shoulder pain, when I do 180 degrees of flexion only, I have pain. Otherwise, I don't have pain. So activity related pain are called as episodic pain. A very easy question. Another picture. What you are seeing in this picture? What you see in this picture? Calf muscle wasting. Calf muscle wasting. So you can see the calf muscles are wasted here. Calf muscle is wasted here because especially you can see the patient with the poliomyelitis, a lot of muscle wasting. When you observe it, you are able to observe it, right? So there's a calf muscle wasting. Right, facet pain in the lumbar spine is relieved by standing position, sitting position, backward bending, or hyperextension. Which position in the lumbar spine, right, facet joint pain relieved? Is it standing, sitting, backward bending, or hyperextension? Right. So facet pain is always relieved in sitting positions, right? So if a patient with a low back pain comes to you and you have to ask which position increases pain. If the patient says sitting increases pain, forward bending increases pain, it indicates the patient having IBDP because sitting and forward bending compresses the anterior surface and pushes the disc on the posterior knee, which starts irritating of the nerves, results in pain. Whereas facet pain always relieved in standing or extension. When you do extension, the pain was relieved. When you stand and when you walk, the pain was relieved. If the patient complains sitting pain, it is IVDP. If the patient complains standing, it is facet joint pain. That's a common difference we'll identify through the history of the patient. Okay, knee flexion is an example for what inflation. Or is it bone to bone, or is it tissue stretch, or is it hard capsular or soft tissue approximation? So it's called as the example for the inflation. Is it bone to bone, tissue stretch, hard capsular, or soft tissue approximation? So knee flexion, not extension. How hard capsular? Hard capsular is now very possible. Right, very good, very good. It's very good. It is the soft tissue approximation because when you ask the patient to bend the knee, the patient's thigh and the calf, and there is a hamstring and the calf muscle is coming into contact, and this is the flexion of the knee. So it is a soft tissue approximation. The soft tissue only will limit the excessive knee flexion. Right? There's no capsule involved in the knee flexion. Right. Clicking is most often found in which joint? Is it hip joint, AMJ joint, shoulder joint, or elbow joint? Which joint has a clicking? TMJ joint. TMJ joint is the joint which has a clicking sound. Other hip joint and shoulder joint will have a snapping sensation where the muscle moves over the shoulder joint will produce a snapping, or the muscle moves over the hip joint will produce a snapping sound. So snapping hip syndrome or snapping shoulder. Clicking sound always found in the PGET because of degeneration of the articular cartilages. This. Okay, one of the very easy questions in this session is nerve root value for radial nerve is C6, C7, C8, T1, C5, C6, C7, C8, T1, C7, C8, T1, or C8, T1, T2. Everyone will know the answer, right? C6, C5, C6, C7, C8. You can see the brachial plexus, which we will not forget because we'll start studying this plexus diagram from our first year, right? Anatomy. Important questions we'll always ask in the examinations. Okay, identify this picture. It's not so obvious, but we can say that what is the difference between what patients is. Meaning of stapler very good because of weakness of the absence also. Excellent. Okay, we will move on to the question number 15. Please bear with me. We'll have another 10 questions. And then just question first. C5, C6 nerve root pathology causes reduction of dash reflexes. Triceps reflex, brachioradialis, radial reflex, or supraspinatus. Which reflex is affected in C5, C6? C5, C6 always knows it is a biceps or brachioradialis, and brachioradialis is the correct answer. Right? It's not tricep jerk or not radial jerk or supraspinatus jerk. Okay, during resistor isometric contraction, the examiner need to observe what. So when you ask the patient or when you do assessment of resistor isometric contraction, what you are going to observe, is it the strength of contraction, range of motion, joint play, or joint destruction? What you are going to find? Because excellent, we want to put the correct answers. Right? Is it the strength of contraction? Because the muscle you are going to assess, you are going to assess the strength of contraction. You are not going to look into the range of motion or joint play or joint destruction in the muscle contraction. That is, we will have to do some other distance. Right, question number 17. The resistor isometric, the movement is strong and painful indicates it's the first degree strain, total rupture of muscle, joint dislocation, or no lesion in the muscle. What it indicates? The movement is strong and painful indicates what? This concept was developed by Janda. Excellent. It is first degree strain. So you can see this picture, you are able to identify better. If the movement is strong and painful, indicates there is no lesion in the contractile tissue. If the movement is strong and painful, indicates local lesion in the contractile tissue, either it's a first degree or second degree strain. If the movement is weak and painful, indicates severe joint lesion around the joint. If the movement is weak and painful, it's a rupture of the muscles. It's the third degree. What is the deformity here? Don't say it is a rheumatoid arthritis. Right? What is a deformity? Patient have some deformity in the proximal interphalangeal joint. It's not Bowden deformity, it's not RA. Cases. Herbert's notes, yeah, it's not Herbert's notes, maybe it is a Boucher's notes. At Herbert's Boucher's notes are the which present on the proximal interphalangeal joint. Distal interphalangeal joint is the Herbert's notes, right? Which is common features of the OA hand. So in the patient with the rheumatoid osteoarthritis of hand, you can identify these nodes. It's a degeneration occurs in the hand. Okay, see 18th question. If the pelvic cross syndrome, which muscles are tight? Rectus abdominis, gluteus maximus, iliopsoas, or external obliques? Pelvic cross syndrome, patient with the low back pain is a common syndrome. We are supposed to know this is the pelvic cross syndrome or lumbar cross, lower cross syndrome. We always say which muscle is tight? The pelvic cross syndrome. Gluteus maximus is tight. Pelvic cross syndrome produces anterior tilting of pelvis. So iliopsoas is the tightened muscle, right? So when you look at here, this is how the crossing occurs. There's a tight muscles process, whereas the muscles are weakened. Here in the low back pain, iliopsoas and lumbar extensor goes for tightness, abdominals and the gluteus goes for weakness. So because of iliopsoas tightness, the pelvis tilts anteriorly, increases lumbar extension, hyperextension of lumbar spine, lumbar lordosis increase, and then the patient will have more low back pain. Okay, in the lab investigation, appearance of the synovial fluid in septic arthritis indicates what? Is it red color, brownish color, clear yellow, or cloudy? How the lab investigation of the synovial fluid looks like? Is it red color, brownish, or clear yellow, or red color? What? How it indicates? Right. So you see the brownish color. Right. So when you do a lab investigation, you do the lab investigation, you are able to find out this classification of synovial fluid. Right. So clear yellow is a non-inflammatory state or trauma. Group 2 is cloudy inflammatory arthritis. Thick exudate or brown is the septic arthritis. Commonly, occasionally seen also in the gout. Hemorrhagic is trauma, bleeding disorders, tumors, fractures. Right. So if you identify the synovial fluid assessment, rheumatoid arthritis or osteoarthritis, and you can see this as a lab investigations. Deep tendon reflex grading 2 means what? Average areflexia, diminished or exaggerated reflex, PTR reflex. Deep tendon reflex grade 2 means what? Is it average, diminished, exaggerated, or areflexia? Right, is it called as average? And when you see the grading, deep PTR grading, the 0 is absent or areflexia, 1 is diminished or hyporeflexia, 2 is average or normal, 3 is exaggerated or brisk, and 4 is clonus, very brisk hyperreflexia. Okay, so what is the picture? Right? Everyone knows the left side is the total hip replacement. What is on the right side? What is on the right side? Can anyone say me what is on the right side? Some replacement has done. What is on the right? It's not process.
Someone in YouTube answered THR.
The THR on the left side, that is correct. What is on the right side? Right side is not THR, obviously, right? It's not total hip replacement. Okay, it is called as Birmingham's hip resurfacing arthroplasty. Right? So Birmingham's hip resurfacing arthroplasty is only shaving the head of the femur as well as the acetabular cavity. So what is the advantage of Birmingham's compared to the total hip replacement is Birmingham's arthroplasty will help you to do full range of motion, a near normal range of motion when compared to the total hip arthroplasty. And the patient was able to do all the activities in the Birmingham's And Birmingham hip resurfacing arthroplasty usually done in the young people, like patients with 30 years, 40 years with severe degeneration, especially if the head of the femur is involved. If total neck of the femur is involved, we are not able to. Only the head is involved, we are able to do this. Okay, so in a pyramidal tract lesion, stroking on the anterior medial part of the tibia produces grade 2 extension. What is the difference? It is not Babinski. I will tell you the answer also. So is it Chaddock's open hands or Babinski? Same reflexes, same signs only it exhibits in a pyramidal tract lesion, same as Babinski. Because Babinski, you are going to score, you are going to do it in the plantar fascia. So what is your? Is it C? Open forms reflex, right? Right, question number 22. Close back question for hip joint is full flexion, medial rotation, abduction, full extension, medial rotation, full extension and abduction, or abduction, lateral rotation, extension. So which is called as close back question. Every joint will have an open back position as well as close back position. What is close back position? Close back position is a position further there is no movement occurs in the joint. Why? When you do a movement above this, it results in the fracture. For example, elbow extension. Elbow extension is the close back position. When you do extension beyond that, it will cause fracture of the elbow. So elbow extension is the close back position for elbow. So for the hip joint, it is full extension, medial rotation, and abduction is the close back position. Further causes either dislocation of the hip or fracture of the hip. So every joint has a close back position, every joint has an open back position. As a manual therapist, or when you do manual therapy or assessment, you have to always keep the joint in the resting position or the neutral position, not to do in the close back position. Okay, very important. Tenderness grading. That is when you do palpation, you have gradings of tenderness. And the grade 2 indicates what? This is winces and withdraws the joint, will not allow to palpate, pain and winces or no pain. So what is the tenderness grading 2? Tenderness grading 2 indicates it is pain and winces. Patient, when you palpate it, patient complains pain and he winces. Right? So it is important grading you are supposed to understand and read it and mark it. Grade 1 is patient complains pain. When you palpate it, patient complains pain. And grade 2 is patient complains pain and winces. When you palpate it, the patient says pain and winces. Grade 3 is pain, winces, and withdraws. He suddenly removes it when you palpate. And grade 4 is patient not also. I have please note that sir, I have severe pain. So that is grade 4 of palpation. For very easy picture, what is the picture? It's the palsy, right? Policeman can or protest it can. Okay, swelling looks harder, thick, gel-like feeling, and warmer indication. You palpate, you have a swelling, and which is look harder, thick, gel-like feeling, and warmer indicates it's the pus, synovial, blood, or callus. What is the swelling? So the pus, blood, callus, or synovial. Okay. So it is a blood. And here is a classification. If there is a blood swelling is always harder, thicker, gel-like feeling. Pus is thick and less fluctuant. Callus is dilated and tough. When a patient comes to swelling, you have to palpate it and identify the differences, right? Okay, question number 25 in X-ray. Okay, I forgot to add the radiological investigation. The radiological investigation, cortical thickness is used to determine the bone of common area which is measured, right? Is it which bone we are going to measure the cortical thickness? Is the third metacarpal shaft, lower end of radius, shaft of femur, or midpoint of clavicle? Which bone we are going to take it for the cortical measurement? So shaft of femur, lower end of radius, midpoint of clavicle, or third metacarpal? And surprisingly, the answer is third metacarpal, right? So we're going to take only the metacarpal X-ray and find out the cortical thickness or weakness in the bone. Okay, I think that is the end of our session. Our last picture. Very easy picture. What deformity the baby has? Particles. Baby has particles, right? So from this, we are going to come to the end of the today's session, and I always recommend you to buy the orthopedic physical assessment book if you are going to choose the MPT in orthopedics or MPT in musculoskeletal system or MPT in sports physiology. Kindly buy this orthopedic physical therapy assessment. It's worth buying it. And I thank everyone for listening. Although today's session was too fast, all these questions are available in the online. I hope the next class I'm going to take it on manual therapy, right? So it is also a focus on the MCQs only. I don't see any of the MCQs available for the manual therapy in the internet also. From since morning I was searching, I was not able to identify any MCQ questions related to the manual therapy. So still I try to identify few questions and come back next week classes on manual therapy. So manual therapy includes whole manual therapy, starting from the main plan till your soft tissue manipulations, myofascial release, PMF, everything is included. So please prepare for that, and we'll see you in the next class. Thank you very much. And I have shared some questions to Mr. Chandra also. So hopefully they can post it in the group, and we will kindly answer the questions. Most of the questions are 90% of the questions I have taken it from the orthopedic physical therapy assessment. Thank you very much.
Thank you, sir. I will forward the questions to the group. Hope they will answer and send it. And dear participants, if you have any doubts from these questions or in any assessment part, you can raise your queries and interact with our resource person. Any doubts? If you don't have any doubts, kindly write in chat box, no doubts, so that we can wind it up.
I think you started sleeping.
Are you all sleepy? And from YouTube viewers, you can also write the queries in your comment box so that we can read it here in Zoom.
Sorry to interrupt. There are so many questions you can pick up from the first chapter itself. Actually, I have 100 questions, especially for the first chapter of orthopedic physical assessment. So if you read the chapters thoroughly for once, twice, thrice, 4 times, you are able to identify a lot of questions.
So next week we can increase the number of questions so that it will make it included. Is it possible?
Yeah, I will try to make it.
Yes, sir. Not in the live session, sir. In the exam part, what we are sending in that.
Yeah, I think. Okay, in addition to the manual therapy, I can add some few questions from the assessment also.
Yes, sir.
So acute stages, if the patient have pain, we are not able to perform as manual muscle testing. If severe pain restricts the manual muscle power testing. That's what Professor Maina has raised the question.
Many of our YouTube participants answered hemiarthroplasty, partial hip replacement,
that is not correct answer. It is called as the Birmingham hip resurfacing. Many hospitals started doing this. But it's not well developed in India, but many UK surgeons who come down to India have started practicing this.
Sir, and few more were answered correctly regarding one question: policeman tips hand, Tips palsy, and even torticollis, and they are answering in YouTube nicely also. Thank you, sir. Thank you so much. And
maybe today's session I just ran out of little fast.
Yes, sir.
Probably next session I'll slow it down.
This is because of my fault too. Actually, we had started by 7 o'clock. We got even I am not that much well known to these technological things. So Duna madam always does it. I didn't remind her actually, so it's my fault actually.
It happens. It happens. No problem.
Yes, sir. This is the first time, and because last year by May 13th only we have started series of webinars, and today we are completing the first year. Tomorrow we are stepping into the second year, and
many congratulations.
Thank you, sir. And all these days, almost we have connected through YouTube more than 250 times. All the times she did it actually. Rarely Rupesh does, and one or twice I just only go live button only I will use. That's all. They kept it ready everything. So I am not used to that. So That's why we are delayed. Hope all will apologize for my. I apologize for my mistake. So thank you, sir.
Thank you,
Good
Mr.
night.
Bye bye.
Yes, sir. Yes, sir. Bye bye. Thank you, Duna madam. Thank you, dear participants. Bye bye. Good night.